It's time to turn down the noise and tune in to News You Can Use, the show that gives you a quick insight into the latest twists and turns in healthcare news, where every diagnosis comes with an order of side-splitting humor. Your hosts are Dr. Nick, a longtime host, innovator, and healthcare wizard who can prescribe a digital dose of innovation to cure even the most ailing operational inefficiencies, and Dr. Craig Joseph, the healthcare guru who can diagnose both patient and software glitches with equal precision, making sure hospitals run smoother than a well-oiled robot doc. So buckle up, because we're diving into the ER of excitement, the ICU of irrationality, and the waiting room of wacky wisdom. Now here's Dr. Nick and Dr. Craig.
Welcome to the month of June. I'm Dr. Nick.
And I'm Dr. Craig.
This week, we'll be dissecting the latest healthcare news, unraveling some of the latest twists and turns, and making some sense of the latest debacles.
Just remember, life's a lot like a breaking news story. Unpredictable, often absurd, and occasionally leaving you wondering if it's all just a cosmic prank.
This week, we take a look at your genetic data, which is now out in the wild if it wasn't before, some AI mergers, COVID vaccines reemerges. It feels like we haven't talked about that in a while.
We also dive into United Healthcare and their problems, as well as CVS and Aetna saying goodbye to the ACA.
But first off this week, I wanted to talk about the medical debt conference that I attended in Washington, D.C. this past week. And it was put on by the Lown Institute. So forgive me, Craig, can you correct me in the pronunciation of Lown? Is that Lown? What do we?
It's one of those. I can commit.
Helpful as usual. Okay,
Yep.
Very helpful.
If I knew, I still wouldn't tell you, but I don't know.
As I said, helpful as ever. I'm just calling it as it is.
I'm here for you.
Yeah, as you always are. So they put on a conference. It was a medical debt conference. I actually posted something online on my blog and then also on LinkedIn that essentially tried to summarize, key learning points. And a couple of things I wanted to do, really to call out the Lown Institute. It was just a great conference. It didn't cost a lot of money. It was, relatively inexpensive, at least, the cost to me to attend. And they assembled this fantastic collection of folks all around various elements or aspects of this medical debt problem. And one of the outstanding comments or notices that somebody highlighted was when they were comparing us to other countries, and they were trying to assess medical debt in comparison to the US and other countries. And the vast majority of the world, when they asked that question, was, "What do you mean, medical debt?
How does that work?"
What is that? And that even included countries that have some aspect of it, but even in places where they have payment schemes, they have deductible plans, there was some just basic, what I would call really intelligent thinking that I heard about. The resounding message throughout was that this was, it's just a pervasive problem, and if you haven't experienced it, just wait. There are so many challenges, and to be clear, on both sides of this table, with hospitals trying to do the right thing, but then when they set, their financial assistance policies, sometimes they catch too many people, and then, they can essentially go out of business. It was just a really informative, well put together conference that I came away learning a lot. If I was to summarize it, I think, the resounding call repeatedly was back to Uwe Reinhardt, it's the price is stupid. But as I sort of summarized in my posts, get the data and show your work so that you can explain why this is just wrong. You need to bring communities with you, because this impacts all sorts of different communities who can bring stories, and where they showed successes in places like New York, Colorado, they had people telling their story, their experience. I just attended a session just now. Two individuals shared their sort of personal challenges with denials. And, you know, where you've got ideas, share them with as many people as possible.
Tell me about the storytelling. Is that just kind of folks talking about their problems, or is this a way of explaining solutions, or
It
both?
it it was both. I mean, I'll give you one simple example, and you know, this just sort of grounds you a little bit. You think about. I have to say that there was the presence of you know folks there. I forget the name of the company off the top of my head, but their principle is to essentially buy medical debt, pennies on the dollar, and then write it off. And the story that they told, and they actually have somebody working in the company that is gathering this all the time on an ongoing basis, an anthropologist that is on staff who goes out looking for this. And the story they told was a $700 debt that was so revolutionary for this mother of two children. You know, it was just such a personal story. And, you know, I know some people will listen to that and say, gosh, $700, not, you know, but that's the point. It's how it's impacting people in their sort of, their world. And this was a
Mm.
life-changing event for this one woman who had $700 of debt wiped out by this organization. And you go, wow, couldn't we do more of this? I mean, that's not solving the problem, to be clear. You're just, you know, you're picking up the tail end of it. But you know, it was delivering value.
Mm.
And it's sort of, I don't want to say tear jerking because, you know, some of it made you angry, or at least it made me angry. But I think we need to be telling the stories because that's the way that people remember. That's the way that they understand.
Yeah, agreed. Agreed. I'm always amazed at the power of storytelling. People throw slides up or data, and it's fine, it's evidence, but just telling a story that sticks with you.
It does. It's the things that you remember. It's the things that at least I remember. So anyway, big shout out to them. You know, super impressed. You know, hope they'll do more of it. I hope people can learn. I know they recorded a lot of it, so hopefully it will be available. People can see it. So anyway, moving on. Should I be surprised? We're talking about COVID again. I remember that
Well,
was
it's
a regular event for you and I for a considerable period of time, and then it dropped off a little bit. But
yeah,
here
I
we
think
are again.
there is a law that says you have to talk about COVID if you have a podcast.
Is it in the omnibus bill?
It's I don't know. It might only
No,
be
I
in
don't
Vermont.
think anybody
It
knows
might
what's in
only be
that.
in Vermont, to be honest. But I'm still. I think we're obligated. Yeah, the COVID vaccine. Traditionally, it's been since its creation. It's been available to anyone for free,
Right.
and
Well,
it's been
sort of.
recommended
I don't know that
for
it's been free consistently. I think you had to
that
have
might be.
insurance, right?
You might be right in the last
Recently.
year or
Yeah.
two. Yeah,
Yeah.
I'm sorry. Thank you for
Hmm.
correcting me. But it had been the government was paying. The government
Right.
had been paying
Yep.
for it, but it certainly had been recommended for everyone 6 months and above
Right.
annually, and that might be changing. And so, with the changing of the guard, we have a new Secretary of HHS and new leaders in the FDA and CDC and other various parts, and they're reevaluating the recommendations for the COVID vaccine. And I have to say, I was not aware that the United States, in recommending it for everyone above age 6 months, was out of step with most of our industrialized peers. The vast majority of which only recommended for elderly folks. And so that age changed from I think 60 to 70, somewhere in between there,
Yeah, there was a
for
lot of
most countries.
variability, right? Yeah.
Yeah, but it was
Or
still,
it was all old.
it was,
Oh,
it was
crikey! I should.
you,
That sounded terrible. No,
I,
it was
I,
all
f-
older people, or whatever the PC term for that is.
No, I feel attacked.
People
I
like
just
you.
want to. I
I'm
just
sorry.
want to say that. There you go. That's the second time now. I feel attacked. Everyone's hearing it. They'll all be called. All of you who are listening will be called for the lawsuit.
Yeah.
And for not just for the elderly or older age folks, but also for people who have underlying medical
Right.
problems like diabetes and heart disease and cancer and those kinds of things. Those are more traditionally around the world who COVID vaccines are recommended for. And it looks like that we are going to be, the US is going to be moving in that direction with a recommendation for those two populations, elderly and people with chronic medical problems.
Right. And I think it was 65 and above, and then chronic problems, correct? Yeah.
In the US, I think. But this is all based off of an editorial in the New England Journal. So the rulemaking or whatever it's called hasn't happened yet. It's not official, but certainly seems from the leadership that that's the direction that we're going in.
It also included a town hall. Did you not manage to watch that YouTube?
I did not watch the town hall. Was there anything? What did I miss?
A couple of talking heads, I think.
Okay. Well, I read what the talking heads
over
were
the
thinking.
paper. Yeah, I'm more efficient reading it too. But no, I agree. We've continued to adjust, although I like you was a little bit surprised. I thought that we were more in line, but obviously not. Does seem to make sense. Where you draw the line and what's chronic conditions, but you got to wonder why it stayed that way. I mean, I am questioning, how do we get to that point? Because normally we're pretty good at sort of pulling back, or maybe we're not. So
yeah, I don't know. I have to say, when I first heard about it, I thought, scandalous. It's scandalous. But then,
and of course that's completely meaningless because we don't know which way your scandal is thinking. But okay,
my scandalism. Well, again, I'm a pediatrician, and I always half joke that I haven't met a vaccine that I didn't like. Most of what most of what I did as a pediatrician was prevent disease instead of treat disease, and most of the way I prevented disease was with vaccines. So
I'm
yeah,
still playing a bit of whack-a-mole in that whole vaccine space with some individuals who keep coming at me with, it causes infertility and a bunch of stuff. It does get a little bit wearing, I've got to be honest.
One way is to not interact with some of those folks who are not to be convinced by data.
Yep, they will not be convinced.
But this is I know we're kind of hammering home this point, but here I am responding to data, right? One of the data points that I was not aware of was that the U.S. is generally out of step in terms of recommendations for the COVID vaccine with most of our peers, and so that's a much more reasonable direction than I thought it had been.
I
several months
hesitate
ago.
to use these words together for you, but brilliant point.
Yeah, I'm. This is what a rational person does, right? A rational person, when presented with evidence that is contrary to their opinion, says, "Okay, I guess I was wrong.
Need to rethink, and
I need to rethink. If only more of us would take this, take the side of okay, here's evidence, and that should inform our thoughts.
Yes. We've certainly seen our fair share of that. So, all right. Have you been genetically profiled, Craig?
I have not been genetically.
No, I'm shocked.
Not in the way that I think we're talking about. I have had some genetic testing, but it's purely focused and medical. It wasn't like I was just interested in finding out some things.
So you never signed up for 23andMe?
That's exactly what I'm telling you.
Okay.
I never signed up for 23andMe.
I was in the early cohort when they were actually really sharing lots of information. I got, it was before they got a slap over the wrist from the, I think it was the FDA that said, no, not allowed, and had to pull it all back. But I got it And I've gone a lot further than that. I've had my full exome sequence. So I've got all 3 billion pairs or whatever it is. And I continue to sort of refine that and post it there's some research sites where you can check out to see what the latest news is. Always intriguing to me, but the 23andMe was the sort of initial driver. But the news here is, well, they went into receivership. I think that was a while back now. And they've been sold to Regeneron.
Yes.
No conflict of interest in the use of that data, although I've heard lots of very warm statements. No problem there. We will protect your information, but I got to say I'm not convinced. And as I've posted elsewhere, I actually went through an extended period. It took me probably 4 to 6 weeks to eventually delete my data. Why, you ask?
Why, I ask?
Oh, thanks for asking, Craig. It wasn't that they wouldn't delete the data, but I wanted to download it before. And there was this big list of data items, and it took them weeks for them to be available. I had to request them, and then I would get emails over the course of the next 4 to 6 weeks saying, oh, hey, we've got this piece of data now. You can download it. So until that all happened, I wanted to save. And then once it happened, I deleted it, and then I got a confirmation, type your name, inside leg measurement, all that kind of stuff to confirm you really want us to delete. So I think my data is gone. So perhaps I'm lucky, maybe not. I don't know.
Well, there are lots of privacy concerns with giving that information to a private company, and then that private company goes into bankruptcy, and but so I think there were a lot of recommendations to delete those data points. So good on you.
Lucky me.
Why don't you email them to me, and then I'll keep them for safe.
I will definitely blow up your email if you want me to do that.
I want every pair. If you would.
Every pair, all 3 billion. Yeah, it is a lot of data. I think the download it's at least 700 megabytes.
Wow.
No, this isn't 23andMe. This is the full exome. But yeah, it's a lot. Anyway, moving on. The omnibus bill is sort of a little bit contextual. I'm going to call it that. I know it's called some other things. Anything you noticed in that stuck out for you?
Well, there are. This is changing. Obviously, it's changing very frequently. So we don't really know where it's going to end up. But yeah, there's some major cuts to Medicaid.
Yep.
I think that's the biggest thing. So tens of millions of people will, as it is now, will lose their health insurance. And again, to clarify for folks, Medicaid covers some young people with specific medical problems and the poor, and Medicare covers the elderly.
I was always taught, well, I was going to say always taught, I only learned fairly recently from one of my children, because I always find it very difficult. I didn't grow up with it, so I get confused between the two, but Medicare for gray hair.
Oh, that's very nice.
Isn't that clever?
I had never heard that before, but that
does help me.
Growing up with it, I kind of have heard that before. But yeah, so Medicare, it's hard to, a lot of politicians are afraid to touch that. Because those are the people that vote a lot, apparently, I'm told.
I'm
no political scientist.
CVS was not terrified to touch it. They announced that they're pulling out of the Affordable Care Act marketplace in 2026. They're pulling Aetna out. That leaves about 17 million people who are searching for healthcare coverage, which just seems a little bit mean, gotta say.
Well, it might be because they're struggling financially, Dr. Nick.
It's funny you should mention that.
Really? Yeah.
They happen to announce their quarterly profits at the same time, which increased by a small 60% increase in profit margin, 1.8 billion, I believe the number was.
Wow, 60 as in 60.
60.
No, that's a big increase.
Yeah, so no, that
Well,
wasn't it. But anyway, I'm going to call out one thing in that omnibus bill that if you haven't heard about it, I'd be surprised. But the AI oversight, the ruling that has essentially said no AI oversight. This was slipped in as one of these, I don't know, pork rinds or something they call them. I'm just confused by these terms.
or grinds.
um,
Yes.
and it mandates that there will be no oversight, and it removes any of the state's abilities to do that. Like, California, who have said that, to be rolled in, if you're using AI to deny care or to do something, you have to actually declare it. You got to show your work, that kind of thing. All gone for 10 years. What has that got to do with the bill?
Well, it's got nothing to do with the bill, but that's how, legislation is done. We stick little things in other. How many pages? There's thousands of pages. They're gonna stick some things in there. Um, it's interesting, the pros of the folks who are against these kinds of AI laws say that it will slow down our forward progress and innovation. And the folks that are for these kinds of laws think that AI is going to kill us.
Hmm.
I might be overgeneralizing both of those sides. In fact, I'm sure I am. But yeah, it's interesting. It'll be interesting to see if it remains, if that gets into the final bill, and if so, if it changes its form. 10 years does seem like a lot of time. Of course, the government, we can pass a law next year, take that all back. So no promises for the future, Dr. Nick.
You seem to simplify government, I'm just going to say, but okay.
I do.
Oh, we'll
Easy.
just pass a law and
Yeah, it's just
reverse that stuff.
yeah, it's totally possible. I learned that from a chief medical information officer once who was getting a lot of slack, or no slack at all, actually, getting a lot of flack for um, uh, configuring the electronic health record in such a way that it followed the bylaws. And a surgeon was very upset, and the CMIO replied in a very packed ICU. Doctor, all you need to do is change the bylaws and we'll configure the technology to support that change. And that's all you need to do. And in fact, he said he promised that if the bylaws were changed within 1 hour of that change, he personally would change the configuration of the EHR. And the guy said, that's all I have to do is just change this bylaw. And he goes, that's all you have to do. And then he went to the doors of the ICU and, pressed the button so that the doors opened. And the surgeon yells out again across this crowded ICU, what are the chances of me changing the bylaw? And he turns around, he looks at him and he goes, 0.
Yeah, right.
And just as he said 0, the doors closed. It was a dramatic moment. That is how I feel about, all we have to do in government is just change the law. It's no big deal.
Oh, that's yes. I was going to ask, knowing what you know about EHR configuration, how likely is it that somebody could do that within an hour? And of course, the punchline to all of this is, try changing the bylaw.
It doesn't matter. I can promise you anything because I know that bylaw is not going to get changed. So,
Where two or
I don't
three are
know.
gathered.
I don't know. Yeah, we'll see. We'll see what happens with the AI.
All right. And then closing out, I came across this USDA DRI, that's Dietary Reference Intakes Calculator. I will put a link in the show notes. It was just, I want to say, just an interesting sort of, custom. It's a custom calculation for what you need in your dietary um, makeup. And the big thing is the protein. We are
Yeah.
dreadfully under recommending the amount of protein. This, pyramid of foodstuffs, which, every time I open a book seems to be ridiculed for, how it arrived and some of the vested interests. I thought it was actually quite interesting. In my particular instance, 63 grams. I think the zero point 0.8 per kilo, which, yes, everybody rushing to convert. That's helpful for you, is it? You know how many kilos you are?
I don't, off the top of my head,
Shocking.
know how many kilos.
Do you know
I
what a
am.
kilo is?
I do. And I used to be very good at converting from one to the other.
I could buy that as a pediatrician. I could buy that because it was probably all in grams and kilos for those little babies, right?
Yeah. Yeah. Well, yes. Yeah. It's interesting just going to this website, this DRI calculator. I think you can just Google it and to see exactly for your height and weight,
Yep.
what you should be getting.
Yeah, there's a few variables, how active you are, and but I think the overriding message is we're not getting enough protein, trying to get enough in, but without killing yourself on too many calories. Just a little bit more custom approach to what we should and should not be eating, which I think is what we really need in all of this. That's been the struggle, that we're sort of trying to do all of this in a way that is giving folks just broad advice that's not exactly right. But anyway, well, unfortunately, we find ourselves at the end of yet another episode. We've explored some healthcare mysteries. Certainly, we've explored many of Craig's mysteries.
Sure.
And that was before they became your emergencies. So until next time, I'm Dr. Nick.
And I'm Dr. Craig.